Good afternoon, everyone, and for some of you, good morning. Welcome to our town hall, the first town hall that we've done fully remote. Thank you for joining us today. Next slide. We have a lot to cover with you today. We'll get started with a general overview of CAQH core and also an industry update. And we're happy to have a representative from NACHA do an update for us. And then we will move on to focus on a couple of our initiatives on a deep dive. We'll talk about value-based payments and our connectivity work. And then we'll have a spotlight on a few of our initiatives, followed by time for Q&A. Next slide. I'd like to get through a few logistical items. If you can follow the webinar along with us by watching this video. If you'd like to get a hand on the material, you can see on this panel that you can access handouts and you'll be able to follow along with us if you'd like to do it that way. In addition, as I said earlier, we do have time for Q&A, but you can ask your question at any time during the webinar. You don't have to wait till the end. Next slide. So let's take a few seconds to do a polling question. Let's go ahead and launch that. I know that for all of you, these are different times and everybody's working remote and your organizations are going through a lot of change. So we'd like to hear from you how strongly you agree with this statement that COVID-19 is impacting your current or future resources for IT development projects in your organization. So we'll just take a few seconds to get a little bit of input from you all so we can kind of see where you are. And let's go ahead and share the results with the audience. Okay. So I think for all of us, this is having a big impact, and thank you for sharing. Next slide. So I'd like to turn it over to our first speaker, CAQH Core Director, Erin Weber. Erin?
Thanks, Jessica, and thank you all for joining us today. That's some interesting data that was just shared. Certainly the coronavirus is having an impact across our industry. And before we go into details, I want to highlight a couple things that we are doing at CAQH Core, particularly around our rule development to help ease the burden on our participating organizations. You'll hear today about a number of different rule development initiatives we have underway. Our team has been really focused on how we can streamline our rule development efforts to limit the burden on participants, particularly thinking about how we can create more targeted straw polls and surveys, staggering those straw polls and surveys across the different work groups, as well as managing the timing of our different work group meetings. So we look forward to continuing to work with you to drive administrative simplification across the industry over the next few months. For those of you that are newer to the organization, on today's town hall, we always like to start off with a brief overview of CAQH Core, who we are and what we do. CAQH Core is an industry-led initiative of CAQH consisting of about 115 participating organizations that come together to develop operating rules that support the standard transactions in healthcare. These operating rules accelerate interoperability, help align administrative and clinical activities, as well as simplify processes. Our health plans participating in CAQH Core represent about 75% of the insured population, so our participation is strong across the industry. We see our role not only as developing the operating rules, but also driving industry adoption, measuring impact, and we also have a certification program whereby organizations can demonstrate their conformance with the operating rules. CAQH Core is the national operating rule authoring entity as designated by the Secretary of Health and Human Services for HIPAA administrative covered transactions. We are governed by a multi-stakeholder board with equal parts providers and health plans, as well as vendor representation, and a number of advisors to the board, including standards development organizations, and other essential partners. Next slide, please. The operating rules that CAQH Core develops really impact the entire healthcare revenue cycle, all the way from the time a patient encounter is scheduled and that eligibility is verified with the health plan, through the payment and the claim submission process, and additionally the management of the health plan membership through enrollment and disenrollment information sharing, as well as premium payment. Next slide, please. On our last town hall, we shared with you a plan to restructure our operating rules. For those of you that have been working with us for some time now, you will be familiar with the phased approach of our operating rules. Since CORE was founded back in 2005, we have developed 5 phases of operating rules, and each phase addresses different transactions across the revenue cycle. Our board decided late last year that it was time to advance how we organized our operating rules, and we have restructured them by the business transactions that they support. So previously, for example, the eligibility operating rules were encompassed in both the phase 1 and the phase 2 operating rules. Well, we have now created a eligibility and benefits operating rule set so that all of those eligibility requirements will fall within a single rule set, and organizations can pursue core certification on the CAQH Core eligibility and benefit operating rules. This slide does a great job of laying out the new rule structure and specifically which operating rules fall within each rule set. You'll see there are now 7 operating rule sets, each of which has an infrastructure rule associated with it. Typically, we also, over time, develop data content rules. So right now we have data content rules for eligibility and benefits, payment and remittance, and prior authorization and referral transactions. On the far right of this slide, I'd highlight that each of our operating rules also has connectivity requirements, each of our infrastructure rules. Because some CAQH Core operating rules are federally mandated, and really that's those first 3 rows in this visual here, the eligibility, claim status, and payment and remittance operating rules, those connectivity rules associated with each of those rule sets are federally mandated as well. As we move forward in our rule development and work with HHS, the CAQH Core board has really envisioned a single connectivity rule to be applied across each of the 7 rule sets. And we are actively working with both NCVHS and HHS, as well as our participating organizations, to make that vision a reality. Next slide, please. Also on our last town hall, we shared with you that the CAQH Core board had sent a letter to NCVHS proposing a CAQH Core prior authorization and connectivity operating rule package for recommendation to the Secretary of HHS for national adoption under HIPAA. NCVHS is the National Committee on Vital and Health Statistics. This is a federal advisory committee to the Secretary on HHS, tasked with covering a number of topics, including the administrative simplification provisions within HIPAA. In that rule set proposed by the CAQH Core board is the CAQH Core prior authorization data content rule, the CAQH Core prior authorization infrastructure rule, as well as the phase 4 CAQH Core connectivity rule. And the recommendation for that connectivity rule is that those requirements be applied to the current federally mandated eligibility, claim status, EFT, and ERA infrastructure rules to help achieve that vision of a single connectivity rule across all of the core rule sets. The board proposed this rule rule package for a number of reasons. They address, in particular, they address a pressing need to improve the automation and timeliness of the prior authorization process. I think we've all heard a lot of discussion across the industry about the need to improve and further automate prior authorization. And these rules really offer a first step for doing this, as well as setting the stage for future operating rules to really even further enable that critical convergence of administrative and clinical data, as well as beginning to support the use of new technologies and existing standards and emerging standards. Finally, the operating rules, as I mentioned, enhance security and promote uniform interoperability requirements across some of these administrative transactions. So we are working with NCVHS to schedule a hearing later this year. Next slide, please. Always on these town halls, we also want to make sure that you are up to date with the latest information on federal health IT policy. I'm sure all of you have already heard that CMS and ONC put out their final rules on interoperability and information blocking a little bit earlier this year. Today, in fact, both CMS and ONC announced enforcement discretion periods for the requirements within these final rules, given the burden of COVID-19. So your organizations will have a bit more time to comply with these requirements. As always, some of the key federal advisory committees that impact the work we do are continuing to meet. The National Committee on Vital and Health Statistics next full meeting is in June. Their last meeting was done virtually, so I am expecting that they'll make some adjustments for this next meeting. HICAC, which is the Health IT Advisory Committee to ONC, continues to meet as well virtually. Their next meeting is next month. Additionally, both ONC and both HICAC and NCVHS have worked together and formed the ONC Intersection of Clinical and Administrative Data Task Force, also known as the ICAD, focused on improving data interoperability and thinking about that convergence between clinical and administrative data. And the first use case they're really focusing on is prior authorization. And that group is meeting on a weekly basis on Tuesdays. All of these meetings are available to the public, and I encourage you to tune in if there is an agenda item of interest to you. The agendas are also posted publicly prior to the meeting. Next slide, please. With that, I'm really thrilled to introduce our next speaker, Brad Smith, who is the Senior Director of Industry Verticals at NACHA. For those of you not familiar, NACHA is essentially the operating rule author in the financial services industry. They maintain the EFT standard for healthcare and have been a great partner to CAQH Core for many years. Brad's going to share an update on the ACH network and some of the work that they're doing over there. Brad?
Great. Thank you very much, Erin, and thanks for having me on the call. I really appreciate the opportunity to speak to all of you. As Erin said, I'm going to take about 10 minutes or so and give you an update on the ACH network, where your EFTs travel, and talk to you about volume and what some trends that we've seen, but also bring to your attention one particular rule that I think could have effect on some of your organizations, especially the larger ones. So I'll get to that at the end. Next slide, please. As you can see by the headline, the ACH network truly is thriving. We saw almost 25 billion payments for all of 2019. We've added 1 billion or more payments every year over the last 5 years. Our 7.7% growth, 2019 over 2018, is the highest that we've seen since 2008. Now, what's really important there is that in the mid, I never know what to call them, the aughts, the middle of the zeros, I don't know what that is, in the early 2000s, I guess, a lot of that data, a lot of that, the payment volume that was in the network and creating the greater amount of volume was the conversion of checks to ACH. So back then, when you were mailing your checks in to a PO box for your credit card or utility payment, those were converted to checks. Sometimes when you wrote a check at the point of sale at the grocery store or whatever, those were converted to checks. So it wasn't really good growth. It was taking volume from another network and adding it to ours. But the growth we're seeing now over the last 5 or 6 years, or even 10 years, has really been native growth, direct deposit, business-to-business payments, et cetera. Now, we are the network that is responsible for moving your stimulus payments. So you're welcome. And hopefully some or all of you have gotten your payments by now. Now, one thing I wanted to talk about was, we're all in the middle of this pandemic now, and how will this affect the ACH network? As you can tell, first quarter really wasn't affected, and I'll show those stats in just a moment. But it's inevitable that we'll see a decline in some volume, some early analysis, and I don't have any firm statistics, but these kind of make sense if you think, logically, that B2B payments, your business-to-business payments, will be going down since there are many businesses that are closed. A direct deposit with more people unemployed, few people getting weekly checks or biweekly checks, or payments, I should say, not checks. Direct deposit volume will be going down. But nothing firm, but that's kind of our feel, as well as discussions we've had with the Federal Reserve and the clearinghouse, which is the other ACH operator. Next slide, please. So looking at the first quarter of 2020, we had 6.4 billion items just in the first quarter. That's a 7.1% growth over first quarter 2019. There were 3.7 billion debits and 2.7 billion credits in that first quarter. Same-day ACH, so these are same-day ACH payments. They are originated by a bank, a financial institution, and they go to the receiver's account by the end of the day, sometimes within hours, depending on the timing. The growth, it was 42% from 2019 first quarter to 2020 first quarter. Very pleased with that. One other change that we think will also fuel some of the growth for same-day ACH is that the dollar amount for one single same-day ACH limit went from 25,000 to 100,000 last March. That increase came into a rule. So we should see more opportunities and more ways to use same-day ACH. Some specific and major transaction types, the volume that we saw first quarter, B2B was up almost 12%, direct deposit up almost 4%. Healthcare made the top 5. I have to thank you guys for the work you guys are doing with your healthcare EFTs. That's up 13.5% over first quarter 2019. Internet payments, those are mostly consumers paying bills or purchasing things online. And P2P, those are your person-to-person payments. That's almost 24%. That's the largest that we've seen in the first quarter. Slide. Get the next slide. Thank you. Healthcare EFTs, just healthcare specifically, the blue column all the way to the right is first quarter of 2020. It does show a little bit down over fourth quarter, but if you go back along this trend, you'll see that first quarter of any year has really been a drop off from the fourth quarter of the previous year. No worries, as I showed you on the last slide, it's still growing, still a larger volume over first quarter of 2019. But that's quite a nice little growth chart, and continue to work on that. The medical field is doing fantastic in this space. They have a large percentage, I think it's 80% of their EFTs are going as, a lot of their payments are going as EFTs. I'm working with the dentists, theirs is much lower. I'm working with the American Dental Association and some other organizations to get the word out as to how we can get more healthcare EFTs in that dental space. Next slide, please. We'll skip to the next one, actually. Thank you. So this is a rule change that I thought you guys should be aware of, and there's good news at the end of this. But NACHA has an existing ACH security framework, which became a rule back in 2013. The original payment or data security requirements were only for web transactions, your internet payments, way back like in 2000. So we started writing those rules like in 1998 when the internet was still kind of like the Wild West. So they were updated in 2013 to say, all right, we need to protect all of our data. Any data, if you are a bank, a credit union, an originator of transactions, a third-party service provider, you're all required to protect your ACH data through your policies, procedures, audits, protect your systems, whether they're in your servers in your building or in the cloud or whatever it might be. You need to protect the data. Now, next slide, please. The new rule, right, expands on the 2013 that says that large non-bank, non-credit union, non-financial institution originators, third-party service providers, so companies providing services to these originators, must protect account numbers, rendering them unreadable when they're stored electronically. So this is a change. We used to just to protect the data. Now, when that data is at rest, you need to make the account number unreadable. Right. So this aligns with PC requirements, with what governs credit card payments and protection of credit card information. NACHA is neutral as to the method to do this and the technology required. I mean, if you need to use encryption or truncation, whatever it might be, or tokenization, any of those will work, but do what's best for your organization. Next slide, please. This only applies to the account number. I want to reiterate that. It's not all the data, but only the account number that's being used in ACH transactions. And this does not apply to if for some reason you have some paper authorizations, only if you've been doing this electronically. Right? This doesn't apply to financial institutions because they already have existing FFIEC requirements or data security requirements and other regulations that require them to do a similar thing. So next slide, please. So here are the details. If you are a large originator, right, which means in this instance you originate 6 million transactions or more per year, you must abide by this rule by June 30, 2021. Now, the poll at the beginning of this session really reinforced and confirmed our decision to delay implementation. This was supposed to go into effect June 30th of this year. Right, with what we're going through now and our discussion with our member banks and other industries, we realized that IT resources are kind of in strain right now. So if you originate 6 million or more ACH or EFTs per year, you need to be pretty big in order to do that many, but you can check. You need to render the account number at rest unreadable by June 30, 2021. Phase 2, if you originate 2 million or more transactions per year, then you must make that account number unreadable by June 30, 2022. Right. Next slide, please. I think it's the last slide for me. I have added 2 web links as additional resources. The first one is more information on this data security requirements for originators. There's an FAQ and some other links in there and way more detail than I gave. Feel free to use that. And also from an ACH processing and ACH resource perspective, we've created a web page on our website specifically about the pandemic and what to do under these extraordinary times and there's excused delay and for returns and that sort of thing. But that gets really way down into the weeds of the ACH rules. You guys might not be involved in that, but that information is available to you. Should you have any questions anytime over the next few months during this, feel free to send me an email, or that is my cell phone number for work. I'm glad to speak to you or respond to your email. That's it for me. Thank you for your time. Next up, the speaker is Lena Gebramariam, and she is the manager at CAQH Core. Lena?
Thanks, Brad. So if we could go to the next slide, please. We will be doing a deep dive on our value-based payments initiative. So in early 2019, Core launched a value-based payments advisory group as an industry collaboration to guide the development of common approaches to the exchange of data in VBP in order to reduce administrative burden and improve patient experience of care. What this advisory group first ended up discussing was the fee-for-service revenue cycle and how that does not meet the needs for a value-based payment. So where are those gaps in trying to apply a fee-for-service revenue cycle to a value-based payment system? From that, we created and drafted a list of 19 opportunity areas that could address those pain points and alleviate the administrative burden. Through a selection process, through lots of discussion, surveys, and polling, they chose the top opportunity area for the focus of a VBP subgroup, which launched this past fall. So the number one opportunity area chosen was provider or patient attribution status. The challenge is that peer providers are often unaware of whether a patient is actually in their attributed population at the point of service. This can leave gaps in care and other reporting gaps until well after the patient visit, requiring providers to fill out lots of end-of-year reporting and taking several hours away from patient care. So here the opportunity area was for a health plan to electronically share the patient attribution status at the time of the patient eligibility check, rather than lists of rosters of attributed patients well after the fact. We can go to the next slide, please. So we talked about patient provider attribution. Want to clarify that attribution matches the individual patient in a population with providers. And this ultimately determines the patients for which that provider, either as an individual provider or as a group of providers, hospital health system, is responsible. So this forms the basis of the analysis for metrics that underpin VBP: total cost of care, quality measures, et cetera. And while health plans often supply attribution information on a regular basis, providers are still left with several questions. So first question, why is this patient in my population in the first place? VBP contracts between health plans and providers can include information on the methodology for assigning patients to a population. However, clinicians that are actually providing the care often don't have that insight into those contracts and may not know why a patient is in their population in the first place, especially if it's a patient that they've never seen before. Second question, who's on first? Patients can be attributed to a single provider or a group of providers, and that can leave ambiguity as to who the primary care provider is responsible for that patient. Furthermore, patients with chronic conditions such as heart disease or diabetes may have a specialist who acts as their PCP, which may not be reflected in the attribution model. Third question, who else is involved? In some models, providers are penalized when patients visit other providers outside of that population. But providers may not have insight as to where else their patient is seeking care. Preventing this leakage is a large incentive in VBP contracts, but without visibility into patient utilization, providers are often aware when this occurs until after the contract period when they see a penalty in their payment. So provider success under the VBP models requires knowing the answers to all of those questions. But before even considering these questions, providers need to know, is this patient in my attributed population in the first place? Next slide, please. So there are currently no industry standards for the exchange of patient or provider attribution information. To streamline this business process, the VBP subgroup is drafting a series of operating rules to enable greater uniformity across the industry. The subgroup is tackling their work into three chunks. First, uniform data content requirements. Here they're drafting operating rules which standardize the maximum data element a health plan may require from a provider when that provider requests the attribution status of a single patient or for their roster of patients. And it also defines the minimum data elements that a health plan must return. These data elements will be consistent across any mechanism of exchange or format. Second bucket, improving the exchange infrastructure. So regardless of that exchange mechanism or format, can we ensure that we can improve the reliability and predictability of that attribution information exchange? These requirements include system availability, exchange frequency, response time requirements, and acknowledgements. Finally, building a connectivity safe harbor. Here we're looking to create that safe harbor for the standard electronic exchange. So whether someone is using an X12 transaction or an API such as Fire, making sure that they're getting those consistent data content requirements and that consistent infrastructure. So the VBP subgroup is well on their way to drafting new operating rules and is meeting through July to finish up their work. Next slide, please. And so here you'll see a basic timeline of our work. So the subgroup so far has drafted these data content requirements and infrastructure requirements and is now tackling creating that connectivity safe harbor. In 2020, the VBP subgroup and connectivity task group are aligning their efforts to build that connectivity safe harbor to support that exchange. So there's still time to join. As we stated, this will be running through July. So if you have any questions or would like to join the VBP subgroup, please contact us. Next slide, please. And with that, I'll pass it off to Emily Tenike, the AQH Core Senior Associate.
Thanks, Lena. So what we want to do now is provide an overview of core connectivity before diving into the goal and specific potential requirements for the connectivity update that is currently underway. On the next slide, we see that connectivity is a generic term we use in the industry for how computers, networks, or information systems connect to facilitate data access and exchange. There are a wide variety of protocols and standards in use within our industry, which over the years has resulted in a hodgepodge of the way data is moved around. The core connectivity rules consist of several of these key components or features of connectivity that you see here on the diagram on this slide. Where the core connectivity rules address these components, they act as a framework for connectivity, but also allow for flexibility. For example, core connectivity has developed rule requirements around the safe harbor, which is a concept that the core participants developed and which establishes a common way to conduct an administrative transaction, which really means that stakeholders are able to quickly set up connectivity for any trading partner that wishes to conduct a transaction. As we move to the next slide, we see an overview of where the industry has been and the evolution of core connectivity and what we're considering for the connectivity update that's underway. Looking at the left-hand side of this diagram, you'll see that prior to core connectivity, trading partners defined their own connectivity requirements, often resulting in a lack of uniform connection standard and proprietary protocols. With phase one connectivity, we established HTTPS over the public internet as a vehicle for the conduct of the eligibility transaction. This was expanded in phase two with a specific set of requirements that was, again, specific to the transactions being conducted and included, as you see here, the use of SOAP, MIME, username and password, and digital certificates for authentication, and also the message envelope metadata. Moving into phase four, we simplified the message envelope as well as the authentication process for requirements down to one of each, so just SOAP and digital certificates. We also defined new interactions for push-pull messaging to facilitate messaging for specific transactions, and also improved transport security requirements, moving up to the more modern requirements at that time. So the 2020 connectivity update that is currently in progress, launched in February of this year, is looking at how we as an industry can move forward with a connectivity method to bring uniformity to X12 and non-X12 transactions and alignment on connectivity and security requirements with industry recommendations. Next slide, please. As we launched the work group in February to update the connectivity requirements, three main goals were really identified. First, we wanted to align the connectivity rule to help support some of the frameworks proposed in the CMS and the ONC interoperability rules Aaron mentioned previously, so that some of the more technical specifications would align with where the industry is headed. Second was looking at establishing and updating our safe harbor requirements and making sure we're supporting existing technologies, but also looking forward to what is emerging to ensure that that safe harbor is able to support both base requirements that are existing today with some of the more legacy systems in place, and also is flexible enough to support some of the more modern approaches to improve interoperability. And finally, as CORE looks ahead to future work, especially in the attachments arena, we want to ensure a single uniform connectivity rule is created that supports the intersection of administrative and clinical data exchange. And some of the specific potential connectivity requirements the work group is considering includes the use of TLS 1.2 or higher for increased security, also looking at the authentication and authorization standards. In the existing rule, only digital certificate is required, but there's a lot of movement in the industry for the use of OAuth 2.0 as an authentication standard. And finally, looking at support and requirements for REST and HL7 FHIR APIs. Right now, our connectivity rule supports the transport of SOAP messages, so adding in some of the emerging approaches for data exchanges. Moving to the next slide, please. Here we see a roadmap for the connectivity update. As I mentioned, the update launched in February of this year, and the work group has worked to identify and agree upon opportunity areas to pursue for the update. At this point in the process, the group is beginning to develop and will soon begin to refine the updated requirements by completing feedback forms, straw polls, and on calls. And after this stage is complete, the work group will finalize the requirements and officially move into the formal voting process. And again, this group is now meeting and is through July 2020, so there's still time to join this group as well. So please reach out with any interest. And with that, I'll hand the call to Bob Bowman, Core Director, to review additional CAQH core initiatives. Bob?
Great. Thank you, Emily. And good afternoon. And just as Emily mentioned, we do want to provide an update on our current initiatives that weren't kind of already dealt with by Emily and Lena. So on the next page, you'll see, or on the next slide, you'll see where we have our 5 different initiatives that are concurrent right now. With Lena mentioned the VBP and the work that we're working there with that group, I do want to give a proper thank you to Troy Smith from Blue Cross Blue Shield of North Carolina, who's been helping lead that group now for over a year. So he's done a lion's share of the work for us and really supported that effort, along with the work that Patrick Murda, Michael Privat, and Megan Sicorso have done from Humana, Availity, and Cigna for the connectivity and security work group, that they've also helped us really drive towards consensus on some of this, and will continue to do that for the summer, just as Emily mentioned. 2 opportunities that we do want to kind of drill down to then on this next section of our presentation is going to be the pilot initiatives for prior authorization and our attachments subgroup work that will also be launching later this summer. But before we launch into a quick update on those, I do want to provide, again, a big thank you for Shannon Baber, Nathan Fisk, Lynn Franco, and Heather Morgan from UW Medicine, Change, United, and Aetna. Many of these co-chairs have been with us for 5 or 6 years on the maintenance progress or maintenance process that we have for our core code combinations. So they've been around for a long time. And if you see them out in the wild or have a chance to interact with them, please say thank you as well for all the work that they've done for us. Moving on to the next slide, I do want to give you a quick update on the progress that we've made on our PA pilots. Since our last touch base with you, we've met with over 25 organizations and have really solidified 2 distinct groups for our pilots. Again, these groups consist of generally a provider, a health plan, and a vendor or a clearinghouse to conduct the transaction, someone to play that intermediary role. And we've identified really 5, but 2 of them are
are further ahead than the other 3. So we're moving forward with potentially 5 different pilots this year and into next on working on some of the problems and challenges with automating the PA process. So again, some of these pilots have an embedded EHR process or system within it, and some don't. But no matter what's really going to be important for us is having a distinct set of measurements across the pilots, right? Each PA pilot will be unique and different, but we do want to make sure that we're tracking changes in volume, tracking changes in time, and what the overall impact is as they potentially implement new processes, new products, new operating rules, and the standards as well to go with them. So we're tracking and trending this to ensure that we can collect and analyze the data and report out to the industry the findings, right? What works, what doesn't work, what are the lessons learned, what is the ROI, and how can we do this better as an industry? Because we know the significant challenges that the industry faces by having a partially manual or fully manual process when it comes to the prior authorization. Next, we're actually going to move to a polling question related to the PA pilot initiative. We won't share the results. This is really for our internal feedback, but we can work with entities that are interested in getting involved, or if you want to learn more, we can also reach out to you as well to make sure that you're up to speed with where our progress is and really how we play kind of Cupid between a provider, a plan, and a vendor or a clearinghouse. So we'll give you just a minute to make your selections before we move on to our next initiative update. So again, if you have an opportunity, please select yes, you want to be involved and be part of our PA pilot initiative if you want to learn more, or if you're not interested right now. Just 5 more seconds. And we'll go ahead and close the poll and provide an update on our attachment subgroup roadmap. Again, as we mentioned, this is another initiative that we have coming up this summer where we'll be launching an attachment subgroup to tackle prior authorization attachments. We're going to begin with this particular use case because, again, prior authorizations and the manual driven process that is in place today really drives a lot of cost and frustration, both with providers as well as health plans. So what we're looking at is this particular scenario for an solicited attachment. Again, this is being based and built off of our phase 4 and phase 5 operating rules. I know we need to no longer refer to them as phases, but for operating rules related to the 278 or the prior authorization transaction. We are looking at the scenarios with using the X12 275 and also for scenarios not using that transaction, potentially the HL7C CDA. So again, we're looking at, we'll be reviewing information with this work group on how, with the subgroup on how to tackle the issues and barriers, right? We're looking at standard availability, consistent acknowledgement for the data that comes in from a provider to a health plan, clearer reassociation between the initial prior authorization request, the request for information, the submission of the information, and then combining those together to make sure that a finalized authorization and determination can be made. Also looking at any specific data or code sets within the transactions or within the metadata of the connectivity that can be used to help enable automation. That's all going to be part of our discussion, as well as the uniform use of a companion guide. Again, understanding how to submit the transactions is often as important as submitting the transactions, right? So we have to make sure that we understand, and the industry understands how best ways and how to model this and information for the industry. If we can move on to the next slide, we'd like to move into our next section, which is our core roadmap. And this is going to be an overview of many of the things of the work items that we're working on, so you can understand kind of how they fit into the different groupings. On the next slide, you'll see that our ongoing maintenance, again with our code combinations, this happens 3 times a year along with a comprehensive review. So this allows for the industry to maintain the core code combinations in a way that ensures compliance with the latest code values that are available for use. Currently under development, again, we're looking at the eligibility and benefits with the VBP rule for attribution data, prior authorizations rule, and the patient provider attribution for benefit enrollment. So see how multiple projects may impact multiple transactions. Again, as Aaron mentioned, we will be working on our core connectivity rule, updating that and bringing it forward for industry consideration. And Emily went through some of those details on exactly what we're looking at and how we're going to move that forward as well. Beyond into 2021 and beyond, we have a lot of input from our core participants related to other challenges that they are faced. And again, we are always open to working with our participants, identifying what those issues are, and then how can we, as a consensus-driven body, pull the industry together and tackle those particular topics. This can be related to specific industry segments like dental. Dental has specific needs for eligibility. It could be new requirements for prior authorization. It could be moving into attachments for quality measurements, customer data sharing requirements, attachments for claims. There's other things that can also be worked on by core, but all brought up from our core participants and our core board leading the charge in how we can simplify and reduce the burden between provider and health plan data exchange. And part of that that can help identify some of those trading partners and partner vendors and clearinghouses that are part of the environments that are working with us is through our core certification process. And that's really our next section as well. If we move to the next slide. You can see that our core certification program has been around since our inception in 2005, and to date we've issued 370 certifications, and they actually cover quite a bit of the industry and different segments of the industry. And although you can see here on the slide between our commercially insured, publicly insured, dental, or even Medicaid government-based insurance, or coverage or benefits, we are moving the needle forward with ensuring that both health plans, providers, clearinghouses, and software vendors that support providers and health plans are working towards implementing and adopting the operating rules and ensuring that the benefits, really the quick and easiness of the exchange of the data, and actually the data is made available for the providers and the plans. Because if you have the data, then it's much easier to actually satisfy the business requirements for the data and also ensure that the interaction that takes place can take place more seamlessly at less cost and be more efficient. So those are all important things that we're working on for certification. Another thing that's also very important for this year and in planning for the next couple of years moving forward, on the next slide, CAQH Core has a recertification program that we'll be launching this year. And this is a process where entities that have completed core certification will now have to recertify on an ongoing basis through time. Many of our certifications today are just snapshots in time. For example, some health plan may have completed phase 1 certification in 2010. Well, they've never recertified since 2010. So for 10 years, those certifications have sat there as a phase 1 certification. Now, obviously, that health plan has probably completed phase 2 and phase 3 and moving into phase 4, always attesting that they're current with the current requirements. But the recertification program will allow for those entities to go through the process and recertify for each of those transactions now. So again, moving from a phase-based approach to a transaction-based approach eases that process, makes it much easier for entities to go through recertification and then to maintain that certification every 2 years. So again, we will work with those entities. We've been able to identify exactly who's in each bucket and where they're at in that continuum, and we'll be outreaching to them and working with them. Again, with that recertification program, we've simplified that process to recertify and also reduce the fees by 50% for recertification. So again, more of this information will come out later this quarter. We'll be reaching out to those entities. And on the next slide, you kind of can see where some of these certifications or recertifications will be applied. So in 2014, you must recertify by the end of 2021. If you've certified between 2015 2016, you have till 2022. Then you can also see from between 17 to 20, you recertify by 2023. So again, we know who you are. We know who those entities are. We'll be working directly with our contacts with each of those entities to make sure that we have support for those entities. We have the resources available for them. We have a gap analysis tool available for them. All of these will be free, available for use to help support the recertification program. Again, it will be based on your most recent certification, for example. So we've done all of the analysis and we'll be reaching out to you to ensure that everything is ready to go when your time comes for that recertification window. So I know many of you may have questions about this or many of the other topics that we talked about today. So I'll hand the call over to Jessica to launch us into our audience Q&A.
Thank you, Bob, and also thank you to all of our prior speakers. I want to put in a plug for a webinar we did a few weeks ago on certification that included a lot of really good information about recertification. It's available on our website if you'd like to look at the video or take a look at the slides from that webinar. So let's take a couple of questions. The first question, I'm not sure if it's for Lena or for Aaron, but the question is, due to the current health emergency caused by COVID, do you foresee an impact on the VBP work that you're doing?
Hi, Jessica. This is Erin. I can take this one. The roadmap for the value-based payment work remains the same. What we have done is looked at the individual tasks assigned to the subgroup to develop the rule and tried to think through how can we simplify and streamline the effort. So we have reduced the number of straw polls that the group will be asked to complete and simplified them, as well as spacing the timeline of calls a bit more appropriately. So the work and the roadmap remains the same, just we have reorganized the tasks a bit.
Thanks, Erin. And the next question is for you as well. So the question is, if the latest proposed rule set is accepted, when is it likely to be required for implementation by businesses?
That's a good question, Jessica. So should NCVHS, the National Committee on Vital and Health Statistics, decide to make a recommendation to the Secretary to adopt the proposed operating rules, a whole process begins then whereby HHS takes the recommendation. Should they decide to agree with the recommendation, what they will do is put out a proposed rule. And that takes several months to draft. They will put out the rule for public comment. Usually it's about a 60-day public comment period. Then they will evaluate the comments, make any adjustments to the rule, and then put out a final rule. Typically, they then give the industry about 25 months from the time that a final rule is published until implementation is required. So when you add all those timelines together, the estimate is 2.5 to 3 years out from now, assuming all the milestones are met in the interim.
And this is Bob, if I can just interject real quick. Many of the core participants, and particularly our board members, they advocate for implementation right away. So they actually begin implementation projects as soon as the board approves the rule set. So many of those leading organizations within our industry jump on board and start that implementation process. So we have entities that completed phase 4 certification and are now working in phase 5, and those rules are not yet required by HHS. So many of the more forward-thinking entities that have worked with us in developing the requirements and the rule sets are moving forward now for implementation.
That's a great point, Bob. Once the operating rule sets are approved by the core participating organizations, they are available for industry adoption.
Thanks so much for the comprehensive answer. So the next question is for, I think, either Emily or Bob. How will organizations that are currently core certified be impacted by the new connectivity rules that are being drafted?
I can jump in, Emily, if you want to fill in anything that I might miss. It's a great question. And the way that we are working the updates to the rules, including connectivity, is that once the work goes through and kind of follows the same path that Aaron just mentioned, once the work is completed and the rule set is approved by ballot, by vote, we notify the industry, both our participants as well as the broader industry. And then entities that this kind of becomes immediately available for adoption. And so we will work that into the recertification program for entities. And as soon as they are ready to certify, that connectivity will be embedded into their recertification program. Like they have to conduct the eligibility with the new certification, or they have to be able to post the 835 or pick up the 835, so remittance advice with the new connectivity. It will be available upon publication. So we work with different vendors testing, third-party vendors, so it's a third-party review. It's not us, it's someone else that actually conducts the technology behind it. That will be available for voluntary core certification for those entities.
Thank you so much, Bob. And so we have time for one last question for Aaron. Aaron, can non-core participants be involved in these rule development efforts?
That's a great question, Jessica. And the answer is yes. You can attend our town hall sessions and our other webinars to provide comments and feedback and hear updates on our rule development efforts. But really the best way to get involved and to get involved in the details of the work is to join CORE as a participating organization, where you can participate directly in our subgroups and work groups and vote on and share your opinions and thoughts and own experiences within your own organizations on the potential operating rule requirements. So if you are interested in core certification, we encourage you to check out our website and email us at core@caqh.org.
Thanks so much. Let's move on to the next slide. And, to piggyback on what Aaron just said, these are some of the reasons why it might make sense for your organization to join CORE as a core participant. If you're interested, please feel free to contact us. Next slide. We wanted to share some of the free resources that we have available on our website. Hope you will take a look. Next slide. And then we wanted to share some of our upcoming education events that are available to you. Again, these are free resources. We have a call next week with X12, and we're going to go through the 278 transaction and also the operating rules for that transaction. And then later on in the next month, we will give all of you an update on our research and measurement efforts at CAQH, not just at CORE. So we're going to have folks talking about work at CAQH as well as at CAQH CORE. Next slide. With that, these are the ways that you can contact us and learn about what we're doing. And I want to thank all of you for joining us today, including our speakers. I hope you have a great rest of your afternoon. Bye-bye.
Thanks, Jessica. Thanks, everyone.